communities can participate through their organizations, and forums are established where people's voice actually does make a difference. And where, and I can just say from my personal observation, when we talk about civil society, we need to make sure that civil society groups from wealthy countries also ensure that people from poor countries have a voice. Because my observation is that they very often represent the people. And then I always have to ask the question, do you really represent the views of these people? Are you in contact with them sufficiently to sit in a meeting in Geneva and be representing their views? We need to make sure that this also happens. The private sector is playing an increasingly important role in global health, in informing decision-making in global health. And we need to make sure that their way of contributing also takes into account the public goods, recognizes their profit-making motive. If they are profit-making organizations, we do have non-profits from the private sector who also play an important role, but that we collectively respect that principle of equity, because it works for all of us. If there are gaps in a poor country, those diseases will sure arrive in the richest countries, and therefore our common vulnerability should determine how we work together on equity. Sorry for that long response, but that is basically what I feel about this.
Thank you. I think it's really interesting what you said. And my follow-up question is, does the private sector play a disproportionate role in these decision-making bodies? Because they obviously do have a commercial background, and they're there for profits. So if you have pharmaceutical companies sitting in these forums making decisions about allocation of resources and vaccines when they become available, do they not then have too much influence? And how do you ensure that there's a balance? And same thing on the other hand with civil society. How do you open up those spaces to African civil society organizations so that they don't have to be represented by Northern organizations?
Yeah. I mean, WHO has gone through a debate of how many years, perhaps a decade, about our relationships with non-state actors. And it was really shaped by the political and, in a sense, ideological views of many member states. There were those who felt very strongly that these are important partners, they have resources, they have strategic approaches that could benefit health globally, including what the public sector is doing. And then there were others who felt very much the need to, because this was WHO, to protect the norm-setting role of WHO from undue influence of some who might have a profit-related motive in influencing policy in certain directions. It took a decade of argument in WHO. We finally arrived at a place where we acknowledge and recognize the contribution of the private sector, and then we have put in place some safeguards against the undue influence driven by profit motives of those public sector organizations that are directly involved in health, for example. So I think there is a constant calibration, and there are those who are very much interested in overseeing the safeguarding of the role of WHO. It's something that we need to be seeking to balance all the time. There is no doubt that the private sector has an important role to play. There is no doubt that sometimes through lobbies that gain a voice through member states in WHO discussions, the private sector might have an influence that might be an undue influence. I think it's just up to all of us to make sure that we guard against this. WHO has certain rules about direct collaboration between the Secretariat and certain types of the private sector where we feel, well, we can't work with organizations that are involved in the tobacco industry, for example. That's official. And then we need to see which others might then represent a danger. And then we need to really look very carefully at the role of the pharmaceutical companies that can make such a huge contribution to global health. But those safeguards are important to keep in place. And then as far as civil society is concerned, having worked with civil society when I worked a lot in HIV/AIDS and also dealing with them in relations with WHO in the African region, I'm dead keen to really make sure, and I ask our civil society, the global civil society organizations, when they speak on behalf of African organizations, so are you really linked to people? And it's up to us in Africa, I do think, to work on mobilizing and supporting, civil society and community voices in our region and ensuring that they come to the table at the global level as well, directly. so that their voices are directly contributing towards deciding.
Thank you so much, Dr. Mweti. I'm going to shift now to Dr. Rees and ask you about the vaccine trials, the clinical trials that are ongoing globally and a couple in South Africa. Dr. Tedros spoke about this nationalism around vaccines and the grabbing of any kind of technology by certain countries globally. I'd like to hear your thoughts on South Africa's clinical trials and just talk a bit about the ethics of what it means that these trials are happening in Africa and how they should benefit people on the continent. And, you know, if that's a kind of nationalism, or does that simply provide a balance? Thanks.
Well, several things to start. I'll start with the specifics of the clinical trials, and I'll make the argument of why indeed we have to do these trials in our continent. So first of all, if you have the development of a vaccine and the only communities that you test it on are, say, from the Northern Hemisphere, you're going to miss out in many ways. First of all, there are very definite biological differences. There are genetic differences. There are differences in exposures to other infections, such as other tropical diseases. There are different disease profiles in every community, and there are different behaviors. So the way that a vaccine works, you can't say that it works absolutely universally in the same way across the globe in all populations. And we've seen this, and we can give many stories of vaccines such as the rotavirus, where we've seen that it had different impacts. So the first thing is we need that data from our own populations in this region so that we really understand the safety and the efficacy of any vaccine in that setting. That's point number one. Point number two is that I think that if we are, as a continent, we have a right to be able to give in an altruistic manner towards scientific and social good globally. So we have a right to be able to put up our hands and say, we want to contribute to solving this pandemic. We want to participate in clinical trials that are properly monitored, that are stringent and ethical. We want to do this because this can be part of our contribution. The third thing is that you could make the argument that if you do a clinical trial in your own setting, and therefore you have people who are being altruistic and giving, then the principle of reciprocity that we have to give back starts to apply. And if no African countries are given that opportunity, it's very easy to say there's no need for reciprocity. We don't have to give back to those communities because we'll give to the Northern Hemisphere communities who have participated in trials. So if we look at all of the basic principles of ethics, then the more we contribute in an ethical framework, the more the balance goes towards saying, then we would deserve to have access. So I think from a clinical trial perspective, those are some of the reasons that we would want to do a clinical trial. In addition, and I think this is really to the credit of the continent and its scientists, and actually, sadly, and Chidi was saying that she's worked on HIV for many years. Sadly, it's partly to do with the fact that we have HIV and malaria and TB, but we do have excellent clinical trial sites and excellent scientists who are able to do large-scale vaccine trials to the highest possible standard. So that's another reason, is that we're using our resources for global good. And just remember, last point on this, is that if you look at the UK, where, for example, the Chadox vaccine started in the UK as the big trial there on the Oxford vaccine, and now it's in South Africa and it's in Brazil. We also we're going to be chasing the outbreaks, because now the numbers of cases went down in the UK, so it's much more difficult to test a vaccine, but Brazil went up and then South Africa went up. So also, unless we have global coverage, we're not going to be in the right place at the right time to actually test a vaccine, because sad to say, you have to have cases to be able to show effectiveness. I'll stop there.
Thank you, Dr. Rees. And do you think that African institutions like the African CDC are funded adequately, are sufficiently strengthened within the various contexts in different countries, are they able to actually increase this kind of capacity so that we can continue to do these kinds of trials, whether it's COVID-19 or HIV, and really make some headway?
Well, I want to, before I answer specifically in the African CDC, I want to really agree with Chidi. I've sat in many committees, in many global committees, where I've repeatedly asked the question, where is the leadership from the global south? Because inevitably, you know, the top scientists, the bulk of research, everything inevitably is coming from the global north, and first-class people, really excellent scientists, excellent clinicians, really good civil society people. But the problem is that the balances remain skewed. So one of the things in this setting and this context is that as a continent, we have to raise our voices. And I'll give you just one little example where we weren't able to raise our voice, and there were consequences for that. Fortunately, not as bad as they could have been. In 2009, we had the pandemic influenza occurred, and a vaccine was made. And I remember sitting on a very eminent committee at WHO in Geneva, and suddenly it dawned on me, there wasn't going to be any vaccine for the African region. Not a single country was going to get access, because all the vaccine had been purchased and bought by the rich countries. So they were going to protect and stockpile vaccine, and there was literally going to be nothing for the African region. As a result of that, WHO created a stockpile, but on that occasion, by the time we got vaccine into the continent, the pandemic had gone down. If we were going to have high mortality, fortunately we didn't, but we would have lost many people. So we've learned from that. But I think that going back now to the CDC and the African Union, the role of President Ramaphosa, the role of the CDC, etc. One of the things we have to do for ourselves is to raise our own voices. So we can't sit on the edges and complain. We actually have to put our hands up and say, we're not complaining. We are on the one hand demanding, and we're making the argument in terms of global equity. We're making the argument in terms of global health, because this epidemiologically is a good thing to do. And we're making the argument because we have the capacity to contribute, and we want to contribute. And so I think that we now have to really raise our voices in a demand and a justified demand framework, not just demand for the sake of demand, but being able to make all the arguments we need to. And one of the things, and Dr. Tedros mentioned this, that we should just remember is that if you take a rich country, even if you had vaccine for everyone in that country, and you had nothing for our region, take a rich country, that vaccine is unlikely to be 100% effective. Say it's 60% effective. So immediately, you're not going to protect everybody. And you're not going to be able to give it necessarily to everybody, because perhaps it won't work in the elderly. Some vaccines don't. So immediately, you're not going to cover those people. And then you're going to have people who refuse to have the vaccine. You go down. So what you might end up with is a cascade that says, in fact, I've only protected half of my population. Half of my population is susceptible. African region, no vaccines. This virus will find every susceptible person on every continent. It'll keep coming back. So actually to say, I'm going to be nationalistic, I'm going to close my borders, I'm going to think of me, epidemiologically and from a global health perspective, makes no sense. We have to think of we in the context of a pandemic.
Thank you so much, Dr. Rees. I'm going to come back to you if we have time on the anti-vaxxers and what we can do. Dr. Moeti, what is it that we can be doing around rebuilding our health systems? We're talking about building back better. That's how we talk in the UN. But how practically is that going to happen? Some countries are obviously taking out loans. You know, the IMF loan in South Africa is a topic of discussion, and other countries will have taken those loans. But what else can we be doing? And what role does the WHO have, say, in pushing for debt relief and using other kinds of mechanisms to help countries rebuild their health systems and their economies? Thanks.
Yes, thanks. Great question. I'll start with the health systems, first of all. I think one of the things that has to be recognized is that building a health system is a long-term project. It's not something that you can do overnight. It's not something that can happen in a few years. I think it requires persistence. It requires a very clear strategy with these principles that we've already talked about of equity. And then it also requires an approach that emphasizes efficiency in the use of the scarce resources that you have. So I think most African countries have figured out where we want to go. We want to make sure that an essential package of preventive and curative services is available for everyone, whatever is their economic status. We have designed and proposed financing strategies for many countries that work towards this principle. I think one of the things that we need to be working on more and more is making sure that the governments themselves do allocate a fair proportion of their domestic budget into this in a sustained way. You know, we cannot have ups and downs. Today, the money is voted. Very often in African countries, the money that's approved does not actually get disbursed. So we need to do this kind of basic, if you like, disciplined way of running a system. One of the other things that needs to happen, just even before the pandemic struck, is to reduce the fragmentation in the way in which we invest in health systems, part of which is driven from the international aid. I do think that African countries now need to be able to say, this is our strategy, this is our plan, this is the way it's going to make the money go furthest in terms of delivering improvements in healthcare for the majority of people. And we'd like you to invest in this way because we have seen in some countries how it works. So, you know, we have the famous examples of Rwanda and Ethiopia, some of the governments that have been able to insist on this principle and that have seen the resources go a longer way. And then we have to see with our own money, how can we make our system more efficient? We know in WHO, we've proven through assessing how systems function, that there are huge areas of inefficiency in our systems, including in the way that hospitals are run, for example. And with just a little more investment in management principles, we've seen how this can be improved. One of the other lesson we've learned yet again from the pandemic is that you need to invest in this before you get hit in the face by a pandemic. We've seen that repeatedly with the Ebola outbreaks in West Africa, with the many outbreaks that African countries suffer. That if we invest in what used to be a very unpopular topic at the international level for donors in health systems, which used to horrify people because it sounded like a kind of bottomless pit of you pour your money down there, it's paying salaries, it's paying for, you know, recurrent costs. I think we've learned the lesson of that. If you invest in that consistently, respecting these principles, looking very much at accountability, efficiency, it can actually build you a resilient health system where when you have the next outbreak, whether it's a pandemic or a severe Ebola outbreak, you are more resilient and therefore the shocks are reduced. I think what we're learning, so if I just give you an example, African countries, after the West Africa Ebola outbreak, African countries did external evaluations. Virtually all our countries evaluated their gaps as far as outbreaks are concerned, and then turned around and did not have financing, neither from domestic resources, which I think is highly regrettable, nor from the international funding, including some of the international partners who had urged strongly this evaluation. So I think if we just invest in so-called peacetime, it'll reap dividends from when we have problems. And then finally, we've learned different ways of doing business from this experience of the pandemic, which I think could make us very much more efficient. We've been pushed around innovation in the use of technology in incredible ways, not only for national systems, but for how countries can work together. By some of the examples that I've seen, you know, groups like Econet with their connectivity and the tools that they're able to help countries to be able to use for contact tracing, for surveillance, not only for this pandemic, but also around whether people are able to access a basic package of health services using technology. This, I think, has taught us a lot. So the financing question, whether this should be grant money, whether it should be loan money, I'm not an expert in that. I would like to say that, again, we need global solidarity in the context where every single country has had its economy severely negatively affected by the pandemic. But again, we need to work with the international multilateral institutions to help those countries that are the most affected, the most vulnerable, that started off in the most vulnerable position, to be able to recover. And just going back to Helen's point about our collective vulnerability. It's a fact of life that we cannot get away from, because our economies are constructed to drive this interconnectedness across the world. And therefore, we need to just deal with this as a fact of life in dealing with how to improve the health of everybody equitably in the world.
Right, thank you. I would like to ask you, Dr. Moeti, to just share some reflections and observations with your work with different African countries in the context of COVID. Have you seen a greater amount of cooperation amongst African countries to come together to increase their bargaining power, to do pooled procurement, and those kinds of things could strengthen the African countries beyond COVID? And I just wonder, reflecting from civil society side, we've seen a tremendous amount of cooperation amongst organizations working on a range of different issues, and having the ability to just come together, again, using technology to push the issues, find solutions, implement those solutions. So I wonder if you can reflect on the countryside.
Yes, we have seen that. And as Tedros said in his statement, I think that the African Union played a very important role in this. And so have the regional economic communities. We've seen ECOWAS, the East African Community, SADC as well. But really, we have to commend the African Union for an unusually action-oriented, pulling a collective approach experience as far as the COVID pandemic response is concerned, which in my experience in many years of having worked with the OAU, then the African Union, has been unique, I have to say. So there's been, of course, we think there were many factors coming into play, that there was an Africa CDC with leadership oriented in this way, and the presidency of President Ramaphosa, and a very pragmatic approach of, okay, let's reach out to the African private sector, African philanthropists who have connections, and then let's create this collective platform. So we have seen this coming together of African countries. I mean, I've seen in some cases countries lending others some of the supplies that they were not able to get. One of the biggest problems we've had has been access to testing kits and supplies. And when speaking to countries, they've been prepared to, okay, we've got a little bit of extra for the time being, prepared to support a neighboring country. One of the most challenging aspects of this pandemic, on the other side, has been the kind of managing the cross-border risk from one country to the next. There, I think, I mean, they've been able to come together in some of the sub-regions and agree on a common protocol. Let's work together, knowing that my people are going to come across infected and your people are going to come here infected. So there's been some exchange. It's one of the more challenging aspects, but on the whole, it's been really very good, I think.
Thank you so much. Yeah, that's great to hear. And I feel that this is a moment in which governments and civil society can work much better together and strengthen those relationships. Dr. Rees, I'm going to come back to you and ask you with your experience as the chair of the South African Health Products Regulatory Authority, whether you think there have been any lessons learned about nations changing their laws or frameworks around medicines, regulation, medical devices, etc. Do you have any views on the kinds of needs that African countries in particular have, and whether those require reforms?
It's a very good question. So drug regulatory authorities in virtually every country are governed by laws, as you say, laws and regulations and guidelines. And the drug regulation it's a conservative discipline of necessity. But what we've learned is that we have to be what I would describe as flexibly conservative. You can't just say it's this way and it can only be this way. What you have to say is this way is optimal, but we understand under these circumstances we're going to have to take all of this into account. So most countries, regulatory authorities do have powers written into legislation, including in South Africa, which allow us to do things differently in the event of an emergency. Similarly, many countries will give powers to the Minister of Health, which allow the Minister of Health to override what would be normal practice in terms of drug regulation. The important thing for people to understand about drug regulation is it's not just medicines, as you said, it's medical devices. In this case, SAPRA has been looking at ventilators and respirators and laboratory tests and many other things that people wouldn't necessarily associate with a drug regulatory authority, but that nowadays is part of the breadth of what a drug regulator looks at. And always the sort of mantra for drug regulation is safety comes first, safety, quality, and efficacy. So even as we push to get vaccines or we push to get better therapeutics or preventive drugs, we are trying to compress the timeline, but it cannot be at the cost of those three issues, safety, quality, and efficacy. So all regulators are now saying, how do we work together within this framework under a pandemic condition, which is an emergency, to ensure safety, quality, efficacy, ensure proper clinical trials that are done to a standard, and ensure that that data comes to us and is reviewed as quickly as possible to allow us to get, for example, a vaccine out.
Right, and in your experience, are the regulators sharing that information freely? Is there transparency between countries and nationally so that there can be kind of accountability at the national level?
It's a very good question. And in fact, one of the other things that's really changing globally in terms of drug regulation is that people are starting to really push for what's called reliance, which means that we share information with other drug regulatory authorities. So for example, South Africa, early on, we realized we were being deluged with antibody tests. And they were the good, the bad, and the ugly. And this is where certainly some people thought to validate those tests. Now, not every country is going to have the capacity as we have between the regulator and a National Health Laboratory Service to do that. So we're sharing that information, not only in the region and the sub-region, but also globally. So we're sharing it, for example, with the CDC, we're sharing it with WHO, WHO is sharing with us. This is certainly a time where people are really sharing information across regulatory authorities.
Right, I think this is really a moment for maximum transparency across the board, just as a principle. I'm going to ask Helen about the anti-vaxxers, and then I'm going to come back to Dr. Mweti for any concluding remarks, and then we'll finish up. But yeah, the anti-vaxxers are about. They are sowing doubts around any vaccine that may come out. We obviously on anti-vaxxers, and is there any messaging that we need to start putting out there in preparation so that people really do trust the institutions? Thank you.
Well, I think if we think about anti-vaxxer sentiment, if you look at sort of richer countries, the history of this partly has come from the fact that vaccines have been so effective that people historically didn't used to see measles, for example. And then people would become what many people would call free riders. They'll say, I don't need to vaccinate my child because let those other people do it. I don't see measles, I don't need to do it. And then you have we've had across the world and in rich countries and in poor countries, measles outbreaks all the time. So one of the things is the success of a vaccine has said to some logical people, I don't see this disease, I don't need to do it, but it comes at a massive risk of building up outbreaks. So that's problem number one. Problem number two is that there have been a lot of misinformation and deliberate fraud, unfortunately, that set the scene for people not to trust vaccines. A long time ago, we had measles, mumps, rubella. That a very famous article was published in the Lancet saying it was an association with autism. It was a fabrication. It had to be withdrawn. The person was disgraced, but it did enormous amounts of damage. As a result, in the UK, all of their immunization rates went down and they had huge outbreaks. So misinformation is the second one that we're worried about. And conspiracy theories also go with that. The other thing, and this is what you've referred to with the Russian, this is, it's easy to stoke these feelings, is people need to feel sure that even as we push to get a vaccine rapidly, that it's going to be safe. So safety is absolutely critical. And that's why I think people are concerned. If you rush any one of these candidate vaccines and you do it and you miss out critical steps and you then end up with something that is shown then not to be safe, it will do enormous damage. So in terms of anti-vaxxers, this is it's viral, it's going around the world. And one of the most important things, and this is a great time to do it because everyone's, calling for a vaccine desperately, actually to say, we can show you the many millions of children's lives over many decades whose lives have been saved, and particularly poor children, but rich children too. Across the globe, we can show you the value of vaccines. We now want a vaccine. And if we do it properly, vaccines are going to be absolutely one of the most critical pillars for preventing this pandemic and stopping this pandemic.
Thank you, Dr. Rees. That's really helpful. And I think important for us, particularly in civil society, to start pushing that message around the safety, quality, and efficacy of the processes, the ethical nature in which these trials are taking place in South Africa and around the world, and that we've got to build that trust. I think that's really critical. So thank you. Dr. Moeti, if you have some concluding remarks, that would be great. And then we'll just come back to Dr. Rees for some concluding remarks, and then we'll close down. Thank you.
Yes, okay, thanks very much. I mean, just to say one word about the anti-vaxxers and Africa specifically. As you know, there's been a lot of discussion about Africans being used as guinea pigs for producing vaccines that they will not have access to, and all the stuff about vaccinating our young women, whatever this is going to be. So I think if there's one message I could plead with you as civil society to support in disseminating, it is this. It is to dispel this idea and to really turn this around, the importance of our joining in this work on vaccines so that we can have a claim to this tool that the whole world is waiting for so eagerly. So people should understand, rich countries are spending hundreds of millions of dollars reserving supplies of vaccine in advance before they even get finally discovered. And this is a fact. So why would they do that instead of helping to rescue their economies that have been negatively affected by COVID-19? So in a sense, to push back against this messaging where we hope not to encounter when the vaccine becomes available, people not accepting to be vaccinated, particularly not accepting to have the most vulnerable people vaccinated. That's one. And then, I mean, just to end, again, back on the issue of equity as far as it pertains to access to the various tools, and to make a plea. There's been a lot of work done at the global level in a multilateral platform coordinated by WHO, by Gavi, with a strong participation of countries both from the North and the South, and academic institutions, those who are working on discovering these tools. And we would like really to see a balanced approach from those who are expected to contribute to access by countries that have fewer resources for their family, for their people, and to secure their own, if you like, national interest in protecting their populations simply because they can pay in advance and secure these supplies. To go back to that issue of collective vulnerability and the fact that we have these shared principles and that we need to make sure that everybody has access. It's not possible for everybody in the world to have access at the same time. We all need to prioritize who needs to get it first, be it healthcare workers, the most vulnerable populations, and then progressively everybody needs to get them. So that's my one plea. And then my second plea is to go back to that principle of, this is one pandemic. Fingers crossed, we will one day arrive at a time when it's under control, the vaccine is out, and we're able to breathe again, and life, the new life beyond COVID-19 takes place. I sincerely hope one of the things that we will take forward is investing in health systems so that they are resilient and that the next pandemic finds countries of every type in a better state of readiness. And as somebody working in African countries, I was astonished by the degree of lack of readiness in what I assumed were better resourced countries. So clearly, this is a collective effort that we need to make, but particularly for our region, the basics need better financing, need to be better in place. And I'd like to plead with people, because first of all, and since you're from a civil society organization, Umunyama, we need to have people demanding basic healthcare and better investment in health in that social compact with their governments done in an equitable way. And then secondly, then at the global level, investing when we don't have a crisis, because it'll be much more efficient when we do have a crisis and we won't have to spend billions in responding yet again. So thank you very much for having invited me, and it's been a great conversation. Thank you.
Thank you so much, Dr. Moeti. And we are certainly pushing the issue of health as a human right and pushing our countries to ensure that they meet their obligations in respect of health rights. And it starts with building those health systems, absolutely. And I think we have to really push in this post-COVID moment to see budgeting that is not regressive, which is currently what we're seeing. Shrinking of investment in socioeconomic rights in health and education and in infrastructure. So we need to turn that tide and move away from austerity because these austerity measures have actually increased inequality and poverty, and we need to turn that around. So thank you so much. Dr. Rees, I'm going to come to you for your final remarks.
Well, just before I came onto this call, I was on a call of a WHO committee that Shidi knows about, where we're looking at one of the things we're looking at is how do you prioritize who gets the vaccine? Given that when we get a vaccine, we're going to have perhaps enough for 3% of the population to begin with. So how do you prioritize? And what's interesting, the starting point of that discussion has been about ethics and principles. It hasn't been about health initially. It was about what are the ethics? What does global justice say? And what does the principle of us all in the world being moral equals, what does that mean? That was the starting point. But the other thing that is very clear in those discussions as we think about how do you prioritize is that every country is going to need to be very transparent about this. It's what you said. Those dialogues have to be extremely transparent within the country, and there has to be a global discussion about who gets vaccines and who gets therapeutics, etc. That is also a healthy discussion, but it has to be driven, and there are global civil society organizations and regional ones that are now really taking up this call and asking for those debates and these dialogues that we're now having. I mean, I just think that sadly, this pandemic has shown us one thing, and I think this is the last point that I think we should raise our voices, is that it's come into a world where increasingly it's going to be nationalism versus globalism and solidarity. And it's put itself into that. And it's the world of me, looking after me, or the world of looking after we. And I certainly know where I would want to place myself. And I would want my family and my community to place themselves, which is, I want to look after we, not just me.
Thank you, Dr. Rees. What a wonderful comment to end on about global solidarity. Thank you so much. I'd like to thank the Nelson Mandela Foundation and Selo Hatang for convening us. Selo, we have a lot of work to do. And obviously, working with the experts is really essential to make sure we get things right. But we continue to call and push for the right to health services and social justice. So on that note, thank you all for spending your afternoon with us. Take care, everyone. Thank you.
Thank you. Bye-bye.
Thank you. Bye.
Bye.
Thank you. Bye.
Thanks, Silo.
Thank you, Silo.